output is going to be the volume of blood that's pumped each minute by each ventricle. So cardiac output, the equation for this is cardiac output is equal to the stroke volume times the heart rate. Okay, so the units that we have for this will be milliliters per minute for cardiac output. Stroke volume is going to be measured by milliliters per beat, and heart rate is beats per minute. So when we look at an average person, they have a heart rate of 70 beats per minute. Average stroke volume is between 70 to 80 milliliters per beat. And so the average cardiac output, when you multiply these two, is about 5,500 milliliters per minute. So if you remember from chapter 13, the amount of blood that we have is about equivalent to 5 liters. And so that means that it takes about 1 minute for all that blood to circulate within our body. Now, big thing here is that the cardiac output of the right ventricle is normally the same as that of the left ventricle. So cardiac output of the pulmonary circuit is equal to that of the systemic circuit. The lungs, however, are going to receive all of the cardiac output, but the other organs are going to share the cardiac output of the left ventricle. This is because pulmonary circulation has low resistance, low blood pressure, and high blood flow as compared to the systemic circulation that has high resistance, high blood pressure, and a low blood flow to it in comparison. So some factors that can regulate cardiac rate include the autonomic nervous system, so this is no surprise. So we can have spontaneous depolarization that occurs at the SA node. And again, the SA node is going to be part of the conduction system of the heart. And so when we have hyperpolarized channels open, this allows sodium to come in, all right? And so that's just a quick review, but what we have are the pacemaker potentials. So these are going here, let me circle this in our control panel, serve as the depolarization stimulus for production of action potentials. So what this means is that each action potential then is going to be accompanied by contraction of that myocardium, okay? So we can have two effects, the first being the sympathetic effect. And so here in this image, what we have is an increase in cardiac rate at the SA node. This is due to neurotransmitters of norepinephrine that comes from the sympathetic axons and epinephrine that comes from the adrenal medulla. So these are going to bind primarily to beta adrenergic receptors, and so these are going to hyperpolarize channels and allow calcium channels to increase the rate. And so we have a calcium-induced calcium release that increases the rate. And so with the sympathetic nerve effect, this is going to have a positive chronotropic effect because it increases the rate of depolarization and also of the heart rate, okay? Whereas the parasympathetic division, here we have in this panel, we have now a slower rate. And so this is due primarily to acetylcholine, which is the main neurotransmitter, from the vagus nerve, and it binds to muscarinic acetylcholine receptors. And this opens potassium channels to slow the heart rate. And so this is termed to have a negative chronotropic effect because what this does is it decreases the rate of depolarization and thus decreases the heart rate. All of this is controlled at the cardiac centers of the medulla oblongata, and so that's affected by higher brain centers within the cerebrum. So what regulates stroke volume are three main variables. And so as a reminder, stroke volume, this is the workload that's imposed on the ventricles prior to contraction, okay? So with the first one, we have the end diastolic volume. This is the volume of the blood in the ventricles at the end of diastole, okay? And so sometimes we see this as termed as preload. And stroke volume is going to increase with increased end diastolic volume. And so again, due to ventricles increasing their workload. The second is total peripheral resistance, or TPR. And so this is the frictional resistance in the arteries. This is now inversely related to stroke volume. And sometimes we call this afterload because this is the ejection of blood from the ventricles. And to eject blood, the pressure generated in a ventricle must be greater than the pressure in the arteries, because as we need to recall, blood flows from high pressure or high to low pressure. Okay, and so having a high peripheral resistance is going to lead to higher amounts of pressure. The third factor that can regulate stroke volume is contractility. And so this is the strength of ventricular contraction. And so stroke volume is going to increase with contractility. And when ventricles contract more forcefully, this means that they pump more blood. And so the proportion of the end diastolic volume that is ejected against the afterload depends on the strength of the ventricular contraction. So all three are going to be related. So normally, under physiological conditions, we have about 60% of the end diastolic volume that will be ejected, and this is termed as the ejection fraction. Okay, so again, the ejection fraction is about 60%. And so this equates to about 70 to 80 milliliters of blood out of the total end diastolic volume of the 110 to 130 milliliters of blood. So part of the intrinsic or built-in properties of the heart include the Frank-Starling Law of the heart. And so what we have are increased end diastolic volume is going to result in an increase in contractility and thus an increase in stroke rate volume. Okay, so these are going to be due to variations in which the myocardium is stretched by the end diastolic volume. And so what we have here is on the y or x-axis, we have the ventricular EDV, and then here we have the stroke volume. So as we increase in contractility, then we also have an increase in cardiac output. Okay, and so factors that include this increase in cardiac output includes sympathetic nerve stimulation. So a big take home here, again, is that as the end diastolic volume increases, the myocardium stretching increases and contracts more frequently, thus increasing that stroke volume. So to continue with this concept, the increase in myosin and actin overlap and increased sensitivity to calcium in cardiac muscle cells is what is the cause of the Frank-Starling law. So let's begin here at the bottom, where this is under normal conditions where the heart is, or ventricles are prior to filling with blood. And as we have stretching of that end diastolic volume of the myocardium, then we have an increase in contractile strength. And so what we have here is there is overlap between actin and myosin. However, as we increase in contractility, then we also have an increase in strength. Okay, so as the ventricles are going to fill with blood, the myocardium stretches, so actin overlaps with myosin only at the A bands. And so here in this picture, this is where it has the largest amount of tension. And so this increases the number of interactions between actin and myosin, and so increases the force of contraction. Okay, so stretching, like what we see here, so this is also going to increase the release of calcium. Okay, and so just like with the skeletal muscle, cardiac muscle has sarcoplasmic reticulum that surrounds the myofibrils, and so we have increase in stretching allows increased release of calcium from that sarcoplasmic reticulum. So with the Frank-Starling law, another factor that we have to consider is going to be the adjustment for rise in total peripheral resistance, okay? So an increase in the peripheral resistance will decrease stroke volume of the ventricles, and this will have more blood remaining in the ventricles, so and diastolic volume is going to increase for the next cycle, as well as the ventricles are going to be stretched more, so they contract more strongly for the next cycle as well. Now, some of things to consider though is that the cardiac output of the left ventricle, which again is for the systemic circulation, must match that of the right ventricle of the pulmonary circulation. So the rate of blood flow must be equal to prevent fluid accumulation in the lungs and deliver oxygen to the rest of the body. Because if that is not the case, then we have problems that occur such as edema or other conditions where we have decreased oxygen, like to the brain, for instance. So some extrinsic control, so outside of the heart for contraction include sympathetic changes for cardiac output. And so norepinephrine and epinephrine will increase contractility by increasing calcium. So if you remember from earlier, where norepinephrine and epinephrine have a positive chronotropic effect, they also have a positive inotropic effect, where the calcium available is increased from the sarcomeres. And so again, this increases heart rate. And so here we have sympathetic nerves are going to increase our cardiac rate. So again, that positive chronotropic effect. But it also has an increase then in contractile strength of that ventricle. Another factor that we have is acetylcholine, where again, this has a negative chronotropic effect. Okay, and so this is going to decrease the heart rate. But that is going to indirectly lead to an increase in end diastolic volume, which will increase contractile strength, which increases stroke volume. However, the increase is not great enough to directly affect cardiac output, okay? So here, really with parasympathetic division, there is no increase, okay? Another factor that influences cardiac output is venous return. So venous return, this is the return of blood to the heart by the veins, all right? And so the end diastolic volume is controlled by factors that affect venous return. And this includes total blood volume and venous pressure. And so this is the driving force for blood to return. So veins typically have a high compliance, and so this is the given amount of pressure will cause more expansion in the veins than arteries, and so veins can hold more blood. And that is because veins have a thinner and less muscular wall than the arteries do. So veins are considered to be these capacitance vessels where 2/3 of the total blood volume is held in our veins. So out of 5 liters, then we're talking about 3.5 liters are going to be held within the veins. All right, and so they hold more blood than arteries, but also maintain a lower pressure. So mean venous pressure, for example, is only 2 millimeters of mercury, whereas the mean arterial pressure is about 90 to 100 millimeters of mercury. Factors that influence venous return. So first thing, sympathetic system. And so this is going to stimulate smooth muscle contractions and to allow for a lower compliance. So the highest venous pressure that we have are in the venules, and so this is at about 10 millimeters of mercury, and the lowest are going to be at the junction of the vena cavas with the right atrium at about 0 millimeters per mercury. Okay. So with the sympathetic nerve stimulation here, what this induces is constriction of those venous vessels, and so that's going to increase the amount of pressure that occurs within the veins. So another factor are going to be skeletal muscle pumps that we find within the veins, and so these are going to squeeze the veins during muscular contraction. And then the third one is pressure differences between the abdominal and thoracic cavities. And so contraction of the diaphragm during inhalation is going to increase that thoracic volume and decrease abdominal volume. And so thus creating higher pressure, and it's going to favor blood flow from the abdomen to the thoracic veins. And then lastly, we have blood volume that will affect the amount of venous return as well. So for instance, when we have conditions like with excessive blood loss, then these are obviously going to decrease the amount of venous return. But when we have increased blood volume, then this is going to increase the blood pressure on that venous return.